Good morning. Welcome to Denver. Long before the tragedies at Aurora, Sandy Hook, and Boston took place, the Arlington County Fire and Police Departments had already begun to plan a response for such senseless acts of violence. The result of these years of joint planning and hard work, Arlington County now has a specific fire, police joint protocol for responding to terrorism and active shooter events. In Arlington, we are very fortunate to have leaders who are committed to providing the highest level of public safety for the citizens who work and live in our county. And I'm honored to present to you three of those leaders today. These men are not only three of the most respected people in the Arlington County government, but are the leaders who spearheaded our active shooter response plan and who continuously push forward to ensure that Arlington remains ahead of the curve on all types of emergencies. Chief Jim Schwartz has been with our Arlington Fire Department for 29 years and was appointed Chief of Department in June of 2004. Chief Schwartz graduated from the University of Maryland with a bachelor's degree in fire administration, executive leader program at the Center of Homeland Defense Security at the Naval Postgraduate School. Most notably, Chief Schwartz served as the incident commander at the Pentagon on 9/11. Chief Scott has 34 years in law enforcement experience, with 12 years serving in the position of Chief of Police. Chief Scott began his law enforcement career as a police cadet with Fairfax County Police Department in 1975. In 1995, Chief Scott was appointed as Chief of Police for Fairfax County. In 1998, he retired from Fairfax County and was named Chief of Police in the City of Fairfax Police Department. He left local law enforcement briefly in 2000 to join federal service when he accepted a position as Assistant Inspector General for the U.S. Department of the Interior. Dr. Smith is currently the Operational Medical Director for Arlington County Fire Department, an Associate Professor of Emergency Medicine at George Washington University, and a practicing emergency physician at Virginia Hospital Center, Arlington, Virginia. In his position as OMD for Arlington, he oversees all medical, educational protocols. He develops new and innovative programs for pre-hospital response to active shooter and explosive scenarios, as well as new EMS subspecialty programs and teams. At this time, I'm proud to present to you Arlington Fire Chief James Schwartz, Arlington Police Chief Doug Scott, and Arlington County Fire Department Chief Medical Director Dr. Reed Smith.
Good morning. It's a pleasure to be here today to talk about this important topic. I want to start by thanking the International Association of Firefighters, President Schaeferger, for their leadership on this extremely important topic and the opportunity to share with you a little bit of what we've been doing in Arlington over the last number of years on response to active shooter events. I also want to take an opportunity to thank the members of Local 2800, without whom we could not have achieved, I think, what we have in terms of a model response capability for active shooter events. The willingness of our members throughout the organization to step up and do something new and contribute to the practices and the procedures that we've developed, really, we would not have accomplished what we've done without their support and without their willingness to step up. So if I could have the first slide, please. What we're going to talk about a little bit this morning is something we refer to as the Rescue Task Force. Now, by way of background, it is an unfortunate reality that these events are happening all too frequently in society today. And it's somewhat interesting that if you look at the last 12 years of our post-9/11 experience, a lot of our training, a lot of our investments have gone into preparedness for terrorist events. And most of that preparedness has been concentrated in the urban areas, in the areas where the populations are most dense. But the fact is that active shooter events are happening everywhere, in big cities, in small towns, These events really don't discriminate, because the unfortunate reality is the people who are perpetrating them know that they can do significant damage whether the area is densely populated or not. If you look back at the events in Columbine back in 1999, there is a lot to be learned from that incident. Eric Harris and Dylan Klebold committed unspeakable acts on school children, school administrators, and teachers. The incident, though, in retrospect, was actually over fairly quickly. The perpetrators took their own lives 45 minutes into the incident, but law enforcement and the fire and EMS responders were not as well coordinated as they might have been, and were slow to respond, at least by the standards of today. What we in the fire and EMS community should recognize is that the Columbine incident was a seminal event in the world of law enforcement. It was that event that caused law enforcement to think differently about these events, to realize that they needed to engage the perpetrators as quickly as possible. And so across this nation, law enforcement organizations developed new tactics to subdue shooters in these kinds of events. And the fact is that the fire and EMS community was slower to react. Our model of response to these kinds of incidents was to apply what we refer to as the barricade model. These are the kinds of incidents that many of us have been to all too often, where somebody in the community, oftentimes under the influence of alcohol or other substances, shoots out a couple of streetlights, maybe is involved in some domestic violence, barricades themselves inside their house or apartment, and we respond in support of the law enforcement agencies that have to get them out. We wait for an all clear. We wait until our law enforcement partners tell us it's a safe environment to enter. The fact is, active shooter events are too dynamic to apply that same level of tactical response. We need to do something different. And if events like Columbine, Aurora, Oak Creek, and Newtown are not enough to convince us, we do also need to consider the more widespread events, less frequent, but still informative. The Mumbai attack of November 2008, Mumbai, India, is significant because it was among the most dynamic events terrorists have ever perpetrated. This is not to diminish the kind of events that we suffered on 9/11 or other events since then, but the fact is the Mumbai incident using explosives, small arms, and the movement of the perpetrators across the city of Mumbai created new circumstances for us to evaluate as we looked at tactical response. The other thing to note for our industry is that in the Mumbai event, fire was used as a weapon. Fire was not used as arson, it was used as a weapon. It was used to attract the attention of the media and to thwart the response of military and law enforcement. Fire as a weapon is a significant dynamic potentially added to these kind of incidents that requires our full time and attention. So with these events in mind, in Arlington County, we decided to look at active shooter events and devise a tactical capability that would step away from the barricade approach when appropriate. We did this through a lot of exercises, similar to the way that I know many departments represented here have gone through over the course of the last couple of years. One of the more informative exercises was one that we conducted at Marymount University, in which Chief Scott and I had the opportunity to witness the exercise elevated on a balcony. And he's going to talk in detail in just a few moments about the conduct of that exercise. But what was so important for he and I as we watched the development of that exercise from that vantage point was to recognize that there were areas on the incident scene that our EMS providers could actually get to victims. Situations where the building blocked the view of the shooter, where routes into where the victims were located were not without risk, but were where we were capable of getting to victims with informed risk. And so we began to think differently about these kind of events. My special operations chief at the time, Scott McKay, came to me at the conclusion of that exercise, and he said, "What do you think?" And my response was, "We need to take more risk." And he looked at me for a moment, somewhat puzzled, and I said, "Look around you. Look at our brothers and sisters in law enforcement. Look at what they're doing. We can certainly accept a little bit more risk given everything that they are putting themselves into in these situations." The fact is that the barricade approach to these kinds of incidents will not work. As we saw in Columbine, a slow response will cause more death. The victims of traumatic wounds will bleed out before we get them if we are waiting for a complete degree of assurance that the incident is clear and that the environment in which we are working is completely safe. We don't work in other incidents with those kind of assurances. When we go into a house fire, even when we respond to medical events, we still have and are assuming some level of risk. With training and practice through exercises, we can achieve the same thing here. And we can accelerate the point of medical care to victims in these kinds of incidents. Through this, we developed what we called the Rescue Task Force. It's our answer to providing rapid medical care to stabilize patients in an area that is clear but not secure. We characterize this very similar to the model that we use to designate areas in a hazmat incident: hot, warm, and cold. And what we are saying is, with a good risk assessment, it is acceptable to operate in the warm zone, which we also refer to as the indirect threat zone. It is not without risk, but through good situational awareness, and perhaps most importantly, partnering with our law enforcement colleagues in a unified incident command situation, we can get the level of situational awareness and a high degree of confidence that we can operate in that indirect threat zone. Our first arriving street medics, which are not tactical medics, I want to be clear about this. In the Arlington County Fire Department, we have been providing TEMS or tactical paramedics to support our SWAT team for more than 20 years. Those are specialized assets that work very closely with the police department, but the model of Rescue Task Force is really just the first people showing up on fire trucks or ambulances, hooking up with their police colleagues, doing that situational assessment I was describing before, and making entry. This is a diagram of the model that we employ here. Typically 2 police officers that are used as security. They will flank the Rescue Task Force, typically 2 EMS providers, one in the rear and one in the front. Their role is security. Their role is to be scanning the environment to ensure the highest level of security and safety for those medics that are entering this indirect threat zone. The police officers do not assess patients. They do not assist with patient removal should we move in a direction to withdraw victims to a casualty collection point. They are responsible for security and the movement of the team only. We've outfitted our responders with ballistic protective gear, vests and helmets. They carry only medical supplies, and though I even in my department have sworn law enforcement officers who do the work in our fire prevention division of arson investigation, we do not permit those folks to be the security team for a rescue task force. We do not carry weapons into this environment. We are looking only at casualty care for the victims. And we have taken very much the lessons from the battlefields of Afghanistan and Iraq, where the military has done wonderful work in tactical combat casualty care, and we have moved in a direction to apply those kinds of protocols to a civilian population under what is known as tactical emergency casualty care. We are working with the victims on the trauma care as quickly as possible and removing them to a casualty collection point where greater level of care can be provided to them. The benefits for us, as I've already stated, are faster access to patients and hopefully better survivability on the part of those suffering trauma from these kinds of events. But as a side benefit, we have increased the already very good relationship that we have with the Arlington County Police Department, such that it is not just in these novel situations that we are working more closely together, but in our daily operations on the street. Both organizations have realized that our success is based more on the collaborative efforts of working together, whether it's a company officer and a watch commander on the street, or command-level officers developing a unified incident command for this or other kinds of incidents. We are getting to patients faster, able to triage and treat them and evacuate them more quickly, and we are becoming far more understanding of how police operations work in non-SWAT operations.